Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. I'm joined today by Dr. Gerald Coakley. Dr. Gerald Coakley is a consultant rheumatologist. He's been one of those for 20 years. So he specializes in things like rheumatoid arthritis, septic arthritis, and all that sort of stuff, as well as ME, chronic fatigue syndrome, and post-viral fatigue. Gerald, great to have you with us. This is not a new thing for you, is it, fatigue? This goes back a little bit longer than COVID. So how did you get into fatigue in the first place?
Yeah, well, thanks very much for the invitation to come and talk to everyone. So it's one of the oddities about fatigue that it isn't really anybody's specialty within medicine. People go to medical school, dreaming of being a surgeon or an anaesthetist or radiologist or cardiologist, and they don't go thinking, I want to specialize in fatigue. So it's one of the common concerns or complaints that patients have when they develop fatigue is, who do I see about it? It doesn't really fit neatly into anybody's specialty. And so what's tended to happen is that, sort of disparate groups of professionals have got involved over the years. So often endocrinologists, because, there's a concern, could it be an underactive thyroid that's making people get fatigued? Or infectious disease doctors, because fatigue often follows infections, or psychiatrists, because often when people have got unexplained fatigue problems, it affects their mental health, and so they develop anxiety and depression. And rheumatologists are another group. So as you said, I'm a rheumatologist, and mostly I'm dealing with arthritis, lupus, and that kind of thing. But I got involved in fatigue not long after I became a consultant, actually about 20 years ago. I was invited to join a small group, an interdisciplinary group working in the private sector, specializing in people with fatigue and fibromyalgia. So I worked with psychiatrists, psychologists, physiotherapists, and I was the physician. And my job was to sort of do the due diligence and make sure that there wasn't a physical health problem giving rise to the fatigue. So I was just invited in as a team member, and I found it really fascinating. I really enjoyed working with physicians and with psychiatrists and psychologists, and I learned a lot from them. And that was a company that went folded basically. And when it did, I just kind of really missed working in that group, and so I decided to set up my own little group in 2007. Getting some of those different disciplines together and trying to help people with chronic fatigue syndrome, or ME, which I've been doing now for the last 13, 14 years with a group of us.
That intrigues me, actually, and I know we're intending to talk about post-viral fatigue on this particular show, but if someone goes to a GP with something which is manifesting itself as fatigue, how does the GP know who to send them to, given that you've already said psychiatrists, endocrinologists, rheumatologists, and probably lots of other specializations could be involved? Well, so there is guidance about what to do. So the National Institute for Health and Care Excellence, NICE, produced a guideline in 2007 to try and help GPs to address this. And it sort of set out the ways in which ME or chronic fatigue syndrome can present, and set out the normal investigations that a GP should do to rule out other disorders like an underactive thyroid or diabetes or celiac disease or inflammatory muscle disease, kidney liver disease and so on. So it set out a list of things that should be done. And then it said, the GP can advise a patient about how to pace and how to sort of deal with the symptoms of fatigue. And if they're not getting better after 2 or 3 months, the advice is to refer them on to an interdisciplinary fatigue service. Right. And there are services of that sort around the country. They're often not very well
funded. They're often difficult to access. A lot of them have been closed down over the last few years. There's also been a lot of controversy over whether the treatments that they offer is effective. So it's a real patchwork, and particularly there's a subgroup of people with ME or chronic fatigue who are very severely affected and are housebound, or in worst cases even bedbound. And there isn't really any provision for people in that category. There's nobody really who's set up to cater for that group. And actually, numerically, it's quite a large group. And if you imagine being bedbound for months or years, and nobody can help you, that's not a good not a good position to be in.
We might return to that later, particularly if I get questions on it. But I know that much of the interest today is focused on long COVID, so-called. But do you want to lead us into that? I mean, whether is post-COVID, is the long COVID the same as post-viral fatigue and so on?
Yeah, well, that's a really good question, and the answer to that question is nobody's really sure at the moment. And almost certainly, it's already clear that long COVID or post-COVID-19 syndrome is in fact not one thing. It's a number of different problems presenting with the common feature that patients so affected do not get better within the expected time frame. So they're 4, 6, 8 weeks later, they've still got symptoms. And
isn't that the same for any post-viral syndrome?
Yes, but it's complicated in COVID, and I'll try to explain why. So we've known that if you think about classical post-viral fatigue syndromes, which we see most commonly with Epstein-Barr virus that causes glandular fever. So for many, many years, it's been known that 1 in 5 people, typically teenagers or people at university, who get glandular fever, 1 in 5 of them will have a persistent fatigue problem for months after a glandular fever. And there are actually lots of infections that can do that. It's not just Epstein-Barr virus, various different viruses, some bacterial infections, some tropical infections. So there's quite a number of conditions that present like this. But what's different about COVID? I mean, in some respects, you're right, it's similar. But in other respects, it is quite different. So obviously, one of the main differences with COVID is that it's killed huge numbers of people throughout the world. And we don't see that with EBV, Epstein-Barr virus, or most of the other infections I've been talking about. So, as well as causing, flu-like symptoms, it can also cause inflammation in the body, in the lungs, in the heart, in the brain, in the gut. It can lead to hyperinflammatory syndromes and intensive care and death. So it's clear that quite heterogeneous or pleiotropic in its effect, this virus. And some of the people who have got ongoing fatigue symptoms or other physical symptoms, tingling and numbness or pins and needles and chest pain and so on, have got serious ongoing organic damage in their bodies. And that's why they feel as they do. They have lung fibrosis and scarring or cardiac fibrosis. And that is different from what we see in classical post-viral fatigue, where, as far as anybody knows, there's no issue with ongoing viral replication or viral damage. It's something a bit more complicated than that. So I think when I think about this problem, I think of it really in two sort of distinct categories. So there's the older multi-morbid person who's probably got physical damage from the virus, and that may be why they have ongoing symptoms. And there's the younger, previously fit and healthy person who gets a minor COVID illness, but then has a fatigue problem which persists for weeks and months afterwards. And I think in people under the age of 40, by and large, what we're seeing is what I would regard as classical post-viral fatigue of the sort that we see in Epstein-Barr virus, and we manage it in a similar way. And so I think it's different in the older age group.
But I think that does introduce some problems, I think, for the younger people, because a lot of the younger clients that I see are really worried that the reason they've got post-viral symptoms is because they've got serious organ damage, heart damage, brain damage, and things like this. So they're worried that they're going to never recover from this. And that makes the problem worse. I mean, so it's not to say that it's a psychological condition, because it's an infection. But if you're very worried and anxious about the situation and worried that you're never going to recover from it, of course, it's going to make the situation more distressing than it would otherwise be. So quite a lot of what I spend my time doing is just reassuring people it's appropriate that actually there isn't any serious underlying disease to account for their symptoms. This is what we see in post-viral fatigue syndromes, and we know how to help people with that because we've been doing it for years.
Are we able yet to come up with any figures on the incidence of post-viral fatigue in COVID as opposed to other syndromes?
Yeah, well, so significant ongoing fatigue that's more than just a few weeks, more than a month or 6 weeks, is seen in about 5%.
And is that more or less or the same as every other post-viral fatigue?
It's pretty similar, actually. It's a bit less than we see with EBV. It's probably a little bit less than we saw with SARS, where it was about 15-20%. But we're still working it out. I mean, you'll see lots of different figures around. So the Office for National Statistics came up with a figure of 1.1 million, I think, and that was in December, just before the second wave hit. And if you take that figure, then that's a lot more than 5%. But if you take, for example, Tim Spector at King's has given a figure of 5% having symptoms for more than 6 weeks, and that's based on his cohort, which is about 1.5 million people logging in their symptoms every day. So I don't think we have a final figure, but it's somewhere around 5 to 10%, something of that nature. Yeah,
actually, Joanne sent in a question asking, well, doesn't flu also kill thousands of people when flu is at its worst? So therefore, isn't that very similar to COVID? Particularly in the big epidemics that we saw in decades gone.
Yes, that's true. But flu, if flu is going to kill you, it'll kill you, and it's over and done with. What we don't see with flu is that people, sort of have, many months stay on ITU, develop end organ damage and things like that. You either with flu pretty much don't survive it, and it's usually the very elderly who get that, or it's a nuisance and you're better in a week or two. So I think COVID is different. You don't see, for example, the hyperinflammatory problems, the clotting problems with flu. Right. You do with COVID.
Okay. Is it a silly question to ask how we would recognize post-viral fatigue in a patient, given that many of them will be coming to us for other reasons and may have it?
Well, I suppose the hallmark of post-viral fatigue, or particularly as it evolves, if it goes on for more than 3 or 4 months, then that's when we tend to label it chronic fatigue syndrome. And the hallmark of that is what's called post-exertional malaise. So, in most people, doing some physical activity, doing some physical exercise will make you feel better. It will make you feel more refreshed and more energetic. Whereas in post-viral fatigue and chronic fatigue syndrome, quite characteristically and unusually, and in fact to the extent that if you don't have this feature, you can't be, it's part of the definition, is that the fatigue will get worse after activity, be that physical or mental. So if your patient has that, then it could well be post-viral fatigue or ME, and if they don't have this feature of symptoms getting worse after activity, then they can't have the condition. And one of the difficulties is that for some people, the onset of fatigue is quick, within hours or of doing exercise, but for other people, it's delayed by a day or two. Yeah. So that if they're on the day, I feel fine, but 2 days later, I can't get out of bed, and I'm in bed for 4 or 5 days. That would be what I would look for really in confirming the diagnosis.
I suppose also written on the tin must be you can't have post-viral fatigue unless you've had the virus. So is it the case that if you had a relatively asymptomatic dose of COVID, you could have a nasty post-viral fatigue syndrome?
Yes, unfortunately it is. So it's a very difficult area and a bit of a moving target. So if we just think pre-COVID for a minute, and we see patients coming with new onset fatigue, the problem is that the symptoms of ME or chronic fatigue syndrome are very similar to the symptoms of flu. So, and you can get ME or chronic fatigue through things other than infections. You can get it through stress, through burnout, through various kinds of mental health crises can provoke it. And so it can be really difficult to be sure whether somebody has actually an infection triggering the thing or not. And it's one of the advantages we have with this COVID pandemic. There are not many advantages, but one of them is that we know pretty much for sure, certainly anyone who got COVID after about July or August of 2020 will have definite proof that they had it. There's a whole load of people who got the infection in March or April last year who think they have COVID, but the testing wasn't available at that time, and so we can't be sure. And generally, the approach that we're being advised to take is to assume if somebody got ill in March or April last year with some kind of viral illness and they're not improving, that we assume that it's COVID. But yes, there are absolutely people who have really trivial infection. Minimal.
But if you took blood tests in those patients, presumably you would still see antibodies, wouldn't you? Which would be an indication that they'd had it.
Well, unfortunately, not necessarily. So there are some people who don't mount antibodies, and also, I mean, I know because I work most of my time in an NHS hospital, and we're all having tests all the time, and so I've got colleagues in the department I work in who had PCR-proven COVID, who had antibodies, and then 2 or 3 months down the line, they don't have antibodies anymore. So the antibodies are usually, in most people, you're right, they do hang around, and one of the ways you can tell whether somebody's had an infection is by doing an antibody test. But they're not totally reliable, and there are people who have had an infection and they're antibody negative.
Does that call into question the value of the vaccines if there are people, I don't know in what scale they might appear, but people who don't preserve their antibodies?
Well, I think it's no. I think it's the short answer. So, but I think if it's one of the reasons why viruses were developed, and even people who've had COVID infection are still advised to get a vaccination, is because the longevity of antibody response after vaccination, particularly with the 2 doses, is much better than after a natural infection.
Oh, I see. Right. It was quite encouraging news today, I think, wasn't there? That I think they found that 100% of those vaccinated twice did produce antibodies in the Pfizer and the Oxford vaccines, I think.
Yeah, I think it's 96%. Yeah, but pretty much it's really, I think, very much better than we reasonably were hoping. Because you look at the effectiveness of a flu vaccination, the cover is much less impressive. So it was really hit the jackpot, all the vaccines, in terms of their effectiveness.
Gerald, Epstein-Barr has raised some interest amongst people. Christina says, is there a link between it and fibromyalgia in later life?
Not that I'm aware of. I mean, the problem with Epstein-Barr virus is that if you look in the general population, the population prevalence of having antibodies to EBV is about 70 to 80%. So most people will have antibodies. And when something is so prevalent as to be almost universal, it's very hard then statistically to work out whether it's influencing your risk of getting fibromyalgia. I think it would be fair to say that the majority of people who have EBV do not get fibromyalgia because just most people don't have fibromyalgia. So
that might actually answer a question from Vladimir, who says he keeps hearing that EBV is to blame for so many things, and he wants to know if there's any truth in that. But it sounds to me as though there's association but no causation in this. Yeah,
I think
there were years when people were researching ME, chronic fatigue syndrome, when there was a real interest for decades in the idea that it was to do with persistent viremia, persistent sources of Epstein-Barr virus, and that somehow persisting virus was causing the symptoms. And I think that's been completely disproved. And so basically, what you get with EBV, most people who get it are asymptomatic, they're completely unaware of it. There's a subsection who get glandular fever with swollen glands, sore throat, malaise for a few weeks, and some of them go on and get chronic fatigue, but most of them don't. The other thing that you can get is, EBV is one of those viruses that does remain within the body. It's not got rid of, and it remains within the bone marrow. A bit like herpes simplex does. And so if later in life, if you become immunosuppressed because you develop a lymphoma or a leukemia, or because you're immunosuppressed because of an autoimmune condition, then the EBV can escape the control of our immune system, and it can cause serious problems. But that's extremely rare. It can cause bone marrow aplasia and this kind of thing. Mm-hmm. But numerically, it's tiny. It's like 0.01% of people who get that. So in the main, EBV is pretty much a non-event, I think, as far as we currently understand.
Okay. As I said earlier on, we were here more to talk about long COVID post-viral fatigue than we are other things, and there are quite a few questions coming in about vaccines and things now because I raised them. But I want to get back to the main subject. Elspeth asked a question: how does one deal with fibrosis of the heart and lungs? She says, "How do you deal with it?" But it may not be you personally.
Well, so there are interdisciplinary teams that deal with this because it's very complicated. So with difficulty, I think is the thing to say. It's not easy to treat scarring of the lungs. That is not easy to treat scarring of the skin or scarring anywhere really. So sometimes there's a degree of reversibility, and there are certainly the early experience with patients who've got inflammation and scarring in their lungs due to COVID is that steroids can be really effective. We know from the studies that were done in the UK during the first wave of COVID that dexamethasone can be, which is a form of steroid, can be really helpful in reducing the serious effects of COVID. But also for those people who've got lung scarring, it can really help healing. After post-discharge. So we've had my respiratory colleagues tell me that they use steroids quite liberally and they can be very effective. I think that's all. I mean, you can get scarring in the lungs due to things like autoimmune disease, inflammatory rheumatic disease, and in those situations we use immunosuppressants as well as steroids. Thus far, I don't think we have any evidence in COVID that that's a sensible thing to do. Mm-hmm. But certainly, I think my experience has been that quite a few of the post-COVID consequences you see, I see people who develop inflammatory rheumatic disease and these kind of scarring problems. They can respond really well to short courses of steroid, and that's mostly what we use.
Right. So what does the rest of the treatment package comprise when you're dealing with post-viral fatigue?
Well, I guess the steps are, so one is the sort of the physicianly bit, which is what I do, the sort of due diligence. So my job is to make sure when people have got lots of symptoms, because typically your post-viral fatigue sufferer will not only describe fatigue, they'll describe lots of other symptoms like problems with memory, thinking, word finding, which is often called brain fog, problems with concentration. They'll have problems like palpitations, shortness of breath, abdominal pain, abdominal upset, tingling, pins and needles, numbness. So they'll have lots and lots of symptoms. And they are very often, because it feels very odd having all these symptoms suddenly, so not unreasonably, they will fear that they've got some terrible multi-system disease that's eating away at their bodies. And the first question you need to try and answer is, have you or have you not? got some terrible things eating away at all your organs. And that's really the role of the physician, I think, is to sort of work that out from taking a history, doing an examination, doing appropriate and judicious tests. So we don't test everybody, endlessly, but we do what seems proportionate in testing to the situation. So if it's a 20 or 30-year-old person who's previously fit and well, we're probably not going to investigate very much. And if it's someone who spent 3 months on ITU with COVID, you're probably going to investigate quite a lot, because the likelihood of you finding something is different in those two groups. So that's the first bit, is just working out what's going on here, doing some prudent testing to check kidney, liver function, all these kind of things. So that's what we do. And then mostly what I spend my time doing is just explaining to people why it is that people get post-viral fatigue, and that it's normal to have lots of physical symptoms when you've got post-viral fatigue. This is just what we see. We always have. We did pre-COVID, and we have post-COVID as well. And so we try and develop a sort of model with the patient for them to understand why it is that they're experiencing these symptoms, to try and normalize them, to make them seem less frightening. We do an assessment of their psychological health, because very often it's affected. And you have to be quite sensitive about this, because people often think that you're sort of saying they're being hypochondriac or they're imagining it. And it's absolutely not about that. It's just about trying to get a holistic assessment of how they are, and that means you've got to assess their soul as well as their body. You see what I mean? Yes. And then, so in terms of what you do next, you basically give people advice and support. It's about saying, if you manage this period right, these next few weeks and months, there's a good chance that you'll get better. What does that mean? So it means, first of all, being optimistic, hoping, having a reasonable expectation that you will get better, because that's what happens with most people. Not catastrophizing, not spending all your time thinking, woe is me, my life is over, I'm never going to get well again. Not, I'm afraid, in the main, looking at Facebook groups and that kind of thing, which unfortunately, in my experience, often just give people the heebie-jeebies and make them worry they're never going to get better. And then we give advice on pacing. So that's, your energy is less than it used to be. You've had an infection, you've not been well. So you've just got to cut down your activities to something that you can cope with, so that you can get a consistent pattern of activity and rest, avoiding boom and bust, where you feel a bit better one day and you do more, and then you spend days in bed. This is a cycle you've got to get rid of. So we talked about pacing. We talk to them about, very often what we find is that these patients have got major problems with sleep. They can't sleep, or they're sleeping too much. They're sleeping half the day as well as much of the night. And these are unhelpful. And so we try and explain why that pattern is not helpful and is likely to perpetuate their problem. And often we find that people are very anxious, and that's understandable, but actually it can make the situation worse. So one aspect of what we do where appropriate is, if people have got developed disordered sleep patterns, they're sleeping too much or too little, or they're very anxious or panicky, then we'll get a psychologist involved to help them deal with that. And it can be hugely beneficial quite quickly. It's surprising how quickly you can see people turn around. And then the other approach is really one of rehabilitation. So that's where I involve other members of the interdisciplinary team, and really, from my point of view, the clinical specialists who are best at rehabilitation are occupational therapists. So they are team members who really specialize in getting someone who's because of a health problem is no longer able to function as they used to. It doesn't really matter whether that's because you've had a virus, or because you've had a leg amputated, or you've had a stroke, or whatever. If something's happened to you catastrophically or suddenly, that means that you were 2 or 3 months ago functioning normally, and now you can hardly get out of bed. How do you turn that situation around? Well, you do it cautiously, slowly, with care and compassion, guided and supported by somebody who's helped other people recover from a situation like that. And that's what occupational therapists do. So I work, for many people, it's just about giving advice and reading material, and I think you'll be all right. Get on with it. And then where people have got lots of sleep problems or anxiety, depression problems, then I recommend psychological therapy. And for people where that's not the case, then it's more a sort of rehabilitation, occupational therapy, gradual increase of physical activity type of approach.
Gerald, given that the NHS system is under a lot of pressure at the moment, and I speak to so many people who are not able to get an appointment with their GP, where's the cutoff for us as chiropractors, osteopaths, physios? If a patient comes to us and they're complaining of things like those that you've described, where's the cutoff where we can give them advice along the lines of, it's going to get better, we know this, we recognise this, but at some point we have to say, no, you need to get a referral, so you need to go and see your GP? Or should we not? Should we just say, we think you've got post-viral fatigue, go see your GP anyway?
Well, I think it would depend on when you're seeing them. So I think if it's early days, if you're seeing someone who's a month or two after having COVID and they're still feeling under the weather, I wouldn't regard that as at all surprising, and I don't see any reason to sort of get in a panic about that, either the therapist or the patient. If you're getting out to 3 or 4 months, or someone is very severely affected and they can't get out of bed, then I think you think this is a serious problem, or they're really not recovering at the rate they should be, and then they should go and see their GP in the first instance, because the GP will have access to an array of services, including the new long COVID clinics that have been set up in the NHS.
Okay. Jennifer's asked about chronic fatigue, which you mentioned before. You said it could go on for months after a viral infection, but she asks if it can relapse and remit over years if it's not managed or treated.
Absolutely, it can, and it very often does. And unfortunately, it can, even if it is appropriately managed and treated. Unfortunately, total recovery from ME or chronic fatigue is probably the exception rather than the rule. So what I usually say to people is, I think if you've got these people relatively severely affected, then it is usually with treatment feasible to expect people to get their life back on track and perhaps back into work and doing normal activities. But it's very often the case that they may not make it back to full-time work. They may not make it back to the kind of exercise levels they were doing before, and they may just have to lower their expectations of what they can achieve. And it's likely that at periods of stress, or if they get another infection or whatever, they may have a setback, and that's not particularly to be surprised about or upset about, because that's just what happens, unfortunately. But as I say, there are some cases, and particularly if you see people early on, they've got post-viral fatigue, they haven't yet developed a chronic problem that's gone on for months and months, I think you could be more optimistic. But certainly if people have had symptoms for 9, 12, 18 months, the likelihood of total recovery forever and ever is quite low.
Is there any sort of lifestyle advice that you would offer people before they get to a stage where they need medical intervention? Pippa's asked whether probiotics are helpful at all in managing post-viral fatigue, something like that.
Well, I don't think there's a lot of evidence about that. I think certainly, making sure that you're getting adequate. I think lifestyle adjustment is important. Making sure you're getting adequate rest, making sure you're not over-exercising, making sure that you're managing stress appropriately, making sure that you're making time for pleasure. What I often see is that people's energy level has gone down, and they put all of their energy and focus into what they see as the most important thing, like, for example, work. And then they have no energy or time to do anything else, to shop, to see people, to exercise, to have any pleasure. And unsurprisingly, that is not sustainable for a long period. And sometimes you have to sort of cut down on everything a bit, including work, to try and give yourself time to maintain a balance in your life while you're recovering.
Okay. getting off that topic a little bit, I don't know who's asked this question, but someone asked what we know about T-cell immunity in COVID-19. And I remember reading a bit about this sort of, I think, early on last year about T-cell immunity.
Yeah, so, well, when you think about the response to a virus, the early response is driven by T cells. So we have CD4 and CD8 cells, which are both T cell subsets. And CD8 cells, their job is to fight viruses. That's what they do. So the initial recognition of a virus is based on a T cell response. The long term, so our ability, unfortunately, to do anything about the T cell response is a bit limited, except through vaccination. So vaccination will allow your immune system to recognize peptides or epitopes on the virus, and so they will prime the T cells to be able to recognize the virus when it comes into the body. And the other thing they will do is the T cells will help the B cells, which produce antibodies, to produce antibodies against the virus, or at least antibodies against the vaccine, which will help provide protection. So you kind of need both bits to get your immunity, both the T cell response and the B cell response. One of the reasons why there's been a lot of interest in this is that it's possible, and this is speculative, but it's possible that in different individuals, which bit of the immune system is activated and in response to COVID may have an influence on whether you develop a post-viral fatigue syndrome or not. It's conceivable that some people mount, for example, a strong T-cell response and they clear the virus and they don't get post-viral fatigue, whereas other people may have a weaker T-cell response and take longer to clear the virus, and it may cause more trouble and perhaps result in more long COVID features. But we don't know the answer to this yet. One of the, there are a few silver linings to the cloud that is COVID, and one of them is that the NIH in the States has put $1.3 billion of research funding into looking at this very question. And it's about $250 million in the UK has gone into it as well. So I think these questions are very pertinent, and I think in a year or two's time, we will have much clearer answers to those questions. But right now, we don't really know.
Okay, we've only got a minute left, so one more question, if I may. I don't know who's asked this, but the question is, do ENT issues arise first, then giving brain inflammation, which then relays into the other symptoms of the body, or systems of the body, I should say?
Yeah, well, I mean, the virus obviously gets in through the nose or the mouth, so that's the way it gets in. It seems then to go to because it attaches to these ACE2 receptors, so angiotensin converting enzyme receptors, which are mostly in the lungs, actually. That seems to be where they get in now. And then subsequently, there is evidence that in some individuals, they go to the brain. It seems to be really rare, but there are certainly some studies that were published from Queen Square, the National Hospital for Neurology and Neurosurgery, of patients getting an encephalitis from COVID, but it's about 0.1%. So we're not sure in the generality. There's a very vigorous blood-brain barrier which stops infections from getting into the brain usually, and I haven't seen data yet to be sure whether it really is getting into the brain. But it does seem to be first of all nose and throat, and then into the lungs, and then it goes around to other parts of the body through the ACE2 receptor.
Brilliant. Gerald, thank you. I know you've got a clinic this afternoon, and most of our viewers will also have patients arriving shortly, if not already. So thank you very much for your time. Thank you for that. I hope it's reassured some of our people that we know something, if not everything, about long COVID and post-viral fatigue syndromes.